Good morning, dear colleagues and friends. It's indeed a pleasure introducing the CREDENCE trial to all of you. And I thought after so many years of having cardiovascular outcome trials, are we still excited or we have gone immune to it? And so I've just kept the name of this particular presentation, Is It Worth Canvassing for CREDENCE? As you know that both CANVAS and CREDENCE were done with canagliflozin. Somehow this molecule was had a little bit of a blemish with some side effects and hence did not sustain in the market as the way the other molecules or its brothers were doing. But this is the exciting area which could change the scenario for the near future or set the pace for other molecules following suit with renal benefits. Is it there or is it not? That's what CREDENCE was all about. It was presented this morning 4 a.m. in Melbourne, and we have got a little bit insight about what the data is all about, which we will be presenting to you. Now, before doing that, let me just clarify that we need a little bit of background check, without which there is no point in straight away hitting into the trial. We need to understand why CREDENCE was being done, why is it important for us, what implications does it have. So we need to know a little bit of background before going into it. Well, the first thing we need to remember is a little bit of worst drug history in the history of FDA. What we conveniently forgot is the past. And the past has taught us that there have been numbers of drugs which has been withdrawn from the market, some of which we have written. For example, if you look at the list, we had the scope of writing Serivastatin for a brief period of time, Rofecoxib, Valdecoxib, Troglitazone. Obviously, we didn't have that with us, but the others. And these were the molecules which were in market, and after deaths, for example, with Rofecoxib near about 27,000 plus sudden cardiac deaths and myocardial infarction, and being in the market for 5.3 years, they were withdrawn. Similar things also happened with the other drugs, and I can show you a few of them. For example, we have Tulfenadine, which was a non-sedative antihistaminic agent. And after 139 cardiac deaths and being in market for 13 years, again a molecule I think we have all written along with Astimozole, it was supposed to be a non-sedative antihistaminic, was withdrawn from the market. Safety was a very important issue, and somehow that safety is something we have completely forgotten. We have all been running for the efficacy of products. It is important, but equally important as the safety of the product. And what is even more important has been a very recent recall of certain products because of accumulation of impurities during the process of making those drugs. If you look at this list, Losartan, and there are a number of companies whose names are written there alongside. And then we have Irbesartan. Remember, these are the agents which made a difference on not only reducing blood pressure, but also improving nephropathy, but have been recently withdrawn from market because of having carcinogenic agents, and they have been found to cause one extra cancer for 10,000 patients being treated with them. So the safety is a very important issue, and we have to remember that and not get overboard exclusively with the efficacy and the superior effects that we have from molecules. And hence the present era of looking at the molecules in more stringent fashions, I think the term cardiovascular outcome trials or CVOT is erroneous because the focus entirely goes on the cardiovascular perspective. But what we know is that the CVOT outcome trials looks not only on the cardiovascular outcomes, but also on an expanded safety issues. We would have never known about the heart failure and saxagliptin part. We would have never known the pancreatitis part. We would have never known the reason why we are very excited about CREDENCE from the safety point of view, which is the amputation and the fracture part. And these are the things which would have not been known to us had these randomized controlled trials culminating in the cardiovascular outcome trials were not done. So the present era of intense scrutiny started with Steve Neeson's analysis or meta-analysis of the rosiglitazone and increased risk of myocardial infarction in 2008, and then FDA from USA and EMA CHMP from European Union. They were more active and started creating the regulatory bodies for the industry. And this is the whole panoramic view of all the trials that had been initiated since then, and it's on. And as you look here towards the left-hand corner, the trials that we're looking at for the future. And this is one of the trials, which is CREDENCE, which we were looking for the future, has now become present, which we'll be presenting to you shortly. Now, in the initial part, the first trials were done with gliptins, and we find majority of these trials were neutral. A lot of questions were being asked, and what's the point of doing this when most of the trials are coming up neutral from the cardiovascular perspective? But there were safety signals, as I said previously, which also came out afresh from these trials. And this entire scenario changed with the publication of the SGLT2 trials, the first being EMPORAGE outcome trial, followed by the CANVAS program, and then DECLARE-TIMI 58, and all of them being positive, with intervening period showing us positive results coming out with the GLP-1 receptor analogs. This question has been put to rest about what's the need to do as cardiovascular outcome trials. Not only we need them, but we need more of them. The European Association of Study of Diabetes says we even need to expose the older drugs, which are so-called immune from cardiovascular outcome trials. They should be now exposed to them, both from the efficacy or the superiority as well as from the safety perspective. I'll be concentrating on SGLT2 this morning. And when the 3 SGLT2 inhibitors and their data was available to us, we found that there was a little of a diverse signal when it came to the primary endpoints, with the empagliflozin coming up and showing us that it reduced cardiovascular death as well as it reduced the MACE and the hospitalization for heart failure. We have seen with the canagliflozin in the CANVAS program a reduction in MACE and a reduction in hospitalization for heart failure. And with dapagliflozin, we saw a new co-primary being introduced, which is again hospitalization for heart failure or cardiovascular death, which was reduced. Based on which we find each of these molecules were given different type of label change, which confuses us. We can use one molecule for one patient. I cannot say I'm going to use one molecule to reduce MACE in my patient, and again another molecule in the same patient to reduce cardiovascular death, or the same patient gets a dapagliflozin to reduce the composite of cardiovascular death or hospitalization due to heart failure. Something is not fitting into the picture. Is it a class effect of whatever we are seeing, or is it really that the 3 molecules are working on 3 different aspects of cardiovascular outcome? Now, in our place, we have generated a hypothesis by looking at the data in entirety. If you look at the EMPORAGE outcome trial, you will find that the reduction in MACE was predominantly pulled to the superior side by a reduction in cardiovascular death, and the cardiovascular death was reduced predominantly by 44% of unassailable causes of death, which were not known, and a sizable portion of that reduction was due to reduction in hospitalization for heart failure. So it seems like hospitalization due to heart failure was pulling the cardiovascular death, which in turn was pulling the 3P MACE. But also we need to remember EMPORAGE was a bit different because there were also reduction in sudden cardiac death from arrhythmias, pulmonary embolism. So this cardiovascular death is a little bit unique compared to the other cardiovascular death that we have seen in the other trials. In the CANVAS program again, there was a reduction in 3P MACE, which was superior. But again, that was pulled by, if you look at the sensitivity analysis of the trial, by the reduction in hospitalization for heart failure or CV death, which was again predominantly pulled by the reduction in hospitalization for heart failure, because cardiovascular death independently did not reduce in the trial. And the same story goes for DECLARE-TIMI 58. The co-primary of HHF or CV death was reduced, but independently CV death did not go down, so it was entirely pulled by hospitalization for heart failure. So we can now create a hypothesis, maybe that what we are looking is actually a class effect. Maybe there are different CV outcomes, different parts of CV outcomes which have been impacted by the trials, but they have all been pulled through by a reduction in hospitalization for heart failure. Now you might argue that's the hypothesis you have generated. To find that out, we did a data, and this is a slideshow of anything. Because I can't see this myself. Okay. What we'll show you is that this was the data done to find out. It's a slideshow, animation. What we find is that the 3P MACE, as you, as you find from this data that we have done, a meta-analysis of all the 3 trials, what we find is that there is the MACE. Forget about looking at p-values from now onward. It doesn't teach us much lesson. Just look at the confidence interval and the block, the black block, which is the effect size. They're all on the right side. So it seems like that the reduction in MACE is sort of a class effect which is pulled through predominantly by reduction in hospitalization for heart failure. Now this is another way of looking at it. There is a diverse signal coming from the SGLT2 trials with reduction in myocardial infarction but no impact on stroke, or rather the stroke is going the other way around. And so we pulled them together in another of our meta-analysis and created a composite called MI plus stroke, which is the atherosclerotic composite. And if you pull them together, we find that for all the three agents, this composite did not go down, unlike in GLP-1 receptor agonists where MI plus stroke composite came down. So predominantly we are looking at a class effect with all the SGLT2 inhibitors, which reduces hospitalization for heart failure and in turn reduces cardiovascular death. And that's why independently, either you find CV death reduction in a trial, or MES reduction in a trial, or the co-primary of hospitalization for heart failure or CV death reduction in another trial. So with this backdrop, let us look at the renal part. That's the cardiovascular part. If you look at the renal part, in all the other trials, there was a signal that there was a reduction in the composite renal outcomes, but they were all exploratory or secondary and post hoc outcomes, which are only hypothesis generating. And that's precisely why we required CREDENCE, which is now published. We required DAPA-CKD, and we also required the EMPA-renal data. Unless these data are seen as a primary endpoint, we can never convert a hypothesis into a theorem. And the way of doing it is the way CREDENCE has done it, and others will follow suit in the near future. So we come here to, from here to the rationale for CREDENCE. So what's the rationale? Because we are all overboard with cardiovascular outcome trials. We are still debating MACE versus CVD versus MI versus stroke. But we are losing the focus on the fact that if you reduce HbA1c or bring down HbA1c to its target, the only two endpoints that we can make a difference are retinopathy and nephropathy. And that too, not all the components of retinopathy or nephropathy. And the basic definition of diabetes based on HbA1c or fasting plasma glucose is via reduction in retinopathy, which is a microvascular endpoint. So we should not forget the microvascular endpoint. They're extremely important, and that thereby lies the rationale of CREDENCE for the first time looking at one of those important microvascular endpoints. So if we go for an evidence-based management and we reduce glucose, we only reduce retinopathy and nephropathy. Today we have agents like SGLT2 inhibitors which can reduce CV death or hospitalization for heart failure. We have GLP-1 receptor agonists which can reduce MI and stroke. But if you look at the box, red box with the two question mark, what about the other two components of microvascular complications? Renal death, ESRD. We are still waiting for it. And this is what we need to know, because diabetes is the leading cause of death from kidney failure. So only when there is a kidney failure, patients do not die directly from kidney failure, but rather they die because of death which is happening as a result of kidney failure. And it is leading, as you can see, it tops the list. It is the list which is above hypertension, above glomerulonephritis, above cystic disease. It is the topmost cause, and we just can't ignore this particular endpoint. And not only this, we have learned from the today 21 years of follow-up of STENOT study that there is a reduction of near about 6 to 7 years of lifespan in those detected with type 2 diabetes. Now on top of that, if they have a kidney disease, whatever be the degree of kidney disease, you find that there is the lifespan losses by another 6 to 7 years. So you're looking at a total of near about 16 years lifespan reduction in the backdrop of diabetes plus established kidney disease. And this can be even subclassified depending on how long the kidney disease was there. For example, if you have type 2 diabetes with 6 years of with early kidney disease, the lifespan loss is around 6 years. If you have type 2 diabetes with early kidney disease, well, you see it's exponentially changing its pattern. So this is something we need to understand as the backdrop. And what's important is how do we make a difference to it? How do we then improve the kidney disease and reduce the outcomes, the adverse outcomes related to them, which is reduction in lifespan and increase in death. And there are only two drugs which have done that till date. One is irbesartan, another is losartan in the renal and IDNT trials. And if you look at those, the endpoints used are exactly what the endpoints have been used by the SGLT2 renal outcomes data, which is doubling of serum creatinine, end-stage kidney disease, or death. Now, since then, a lot of drugs have been tried. A lot of new drugs have been tried, including the drugs like renin inhibitors, aliskiren, or a combination of ACE ARBs, but nothing have worked as far as making an impact on the nephropathy outcomes were concerned. And hence we need drugs from our own arsenal, our own anti-hyperglycemic agents. If they can do the job, that's the best possible outcomes. We are anyways using them for reducing blood glucose. So in addition, if they make an impact on macro and microvascular complications, that's the ideal scenario. If you look at the CREDENCE enrollment, it started way before even the other outcome trials were even published or even presented. So it's quite a long timeline that this study had in designing its structure. And if you look at the type of nephropathy patients who were recruited in the trials, for example, in the DECLARE trial, in the CANVAS trial, in the EMPOURAGE outcome trials, obviously they had to follow their package insert, and most of the cases the mean eGFR were all above 60. So they were not entering in the true CKD zone. They were all above the true CKD zone, definitely CKD2 and above, but not below that. So you can see this is the latest way of depicting chronic kidney disease. You have albuminuria on one side and declining eGFR. You have to combine them together to calculate the outcome risk for the future. So why is CREDENCE important? It is definitely important because of number of issues. And one important issue is what we just rolled out as a possible drug which can reduce the renal outcomes, or at least stall the worsening of renal outcomes from the point of initiation of therapy, number one. But CREDENCE also has a point to prove. It also has something to supplement or complement the CANVAS trial, and that is a safety perspective. A lot of questions on the safety has come up exclusively on canagliflozin. Here is a wonderful chance because we are looking at a very sick population of patients with established CKD, long duration of diabetes, very high prone to developing the amputation and related problems. So that also is how CREDENCE is important. Secondly, from the renal perspective, if you look at the other SGLT2 trials, we find that as the eGFR is going down, we find the entire benefit on the renal outcome is actually diminishing. So that is extremely important to find out whether canagliflozin follows suit or takes a different path. Also, we need to remember this comparison is not fair because those were exploratory analysis. This is a primary endpoint analysis. So now let's look at the baseline characteristics of the CREDENCE trial. And this is the design, how the trial was done. What is important to know that at pre-screening, the eGFR, albuminuria, proteinuria was mandated. Obviously, if you're doing a primary renal outcome trial, this is what you have to do. Then you have to optimize medications, the lipid-lowering medications. The blood pressure has to be optimized in both the arms. Otherwise, the credit will go to either a blood pressure medicine or will go to blood pressure reduction, and the molecule will not get its due credit. It's interesting to note that there were 22 sites from India which also recruited patients for the CREDENCE trial. So at entry, the criteria is an HbA1c between 6.5 and 12. The eGFR is between 30 and 90. So if it works, we can now bring down the approval of the eGFR to around 30 ml per minute. The urine ACR is in the macroalbuminuric to the frank proteinuric stage. And we find that the maximum tolerated dose of an ACE or an ARB were prescribed in these patients for more than 4 weeks prior to randomization. Once the baseline and the run-in periods were matched in both the arms, then one group were put on canagliflozin 100, another group was put on placebo, and followed up for near about 5.5 years, quite a long follow-up compared to most of the other cardiovascular outcome trials. If you look at the mean demographics, mean age is around 63 years, predominantly the male population. Mean duration of diabetes 16 years. 97% of the patients were hypertensive. CV disease was there in half of the population of the patients who were recruited, and 5% of the patients had prior amputation. Again, quite important because majority did not have a prior amputation. So this trial is going to tell us whether canagliflozin induces a new amputation or not as a side effect. If you look at the baseline characteristics, were all matched from as far as glucose lowering therapy and the venoprotective drugs were concerned. If you look at the baseline risk factors, A1C, BMI, blood pressure, lipids were all matched in both the arms. If you look at the baseline renal characteristics, this is interesting to note because the vast majority of the patients had their eGFR somewhere between 30 to 60. And the urine ACR, the majority of them were having somewhere between 300 milligrams per ml to 3 grams milligrams per ml. So these were frankly established nephropathy patients who were recruited in the trial. The primary endpoint for CREDENCE trial was a composite of doubling of serum creatinine, initiation of the renal transplant, which is the end-stage renal disease, renal death or cardiovascular death. Secondary endpoints were the composite of cardiovascular death or hospitalization for heart failure, and CV death, all-cause death, renal composite endpoints, as well as cardiovascular endpoints looked from a secondary perspective. So now the main part, which is the result. So having a matched group, and we have looked at patients with frank and established nephropathy included in this trial. What does the result tell us? First, the result on the metabolic effects, and the first effect that we see is obviously on HbA1c. These are glucose lowering therapy, so HbA1c is important. And you find that, as expected, there's a rapid drop in HbA1c right from day one with the use of SGLT2, but we need to match the two and have a glycemic equipoise, otherwise we can attribute this benefit to a reduction in HbA1c. So the other arm was up titrated. At the end of the trial, if you see, the mean difference between the two was 0.25% difference in HbA1c. As you know, FDA mandated 0.4% as the cutoff for glycemic equipoise. So this study completely satisfies that criteria. Systolic blood pressure was extremely important, because if there is a difference in systolic blood pressure by 4 or more millimeters of mercury, then you have a high chance of that reduction translating into outcomes benefit. So here the difference was 3.3 millimeters of mercury, within the range, did not cross the 4 millimeters mark. So BP cannot be a reason for whatever outcomes that we're going to see. Body weight, again, at least 10% of body weight from a baseline reduction is required to make a difference in outcomes. And if you look here, the difference was only 800 grams. So it is nowhere near even the 5% mark if you really want to be a purist. So body weight difference is also not going to make a difference. Albuminuria. Now let's come at the effects one by one. If you look at the urine ACR or albuminuria, remember most of them already had macroalbuminuria at presentation. And if you look at the difference and the confidence interval, 95% confidence interval, there is a significant difference between cana and placebo. So whatever other agents we're using in the other arm were inferior to use of canagliflozin as far as reducing albuminuria from that point at which it was initiated. So it was superior. The second point that we need to look at is the effects on eGFR, and that's extremely important, looking at the eGFR. And this is, for the first time, we are having data showing a first time an anti-hyperglycemic molecule showing a decline, arresting the decline in eGFR, and even persisted over the entire 5.5 years, way superior than the placebo arm. So this is, for me, the main take-home primary message from the CREDENCE trial. Reduction in albuminuria might be temporary. Albuminuria might come back, microalbuminuria might come back to normal. Macroalbuminuria might also improve if it's on the lower side. But eGFR decline invariably leads to a decrease in quality of life, a decrease in bone architecture, anemia, and many other complications. So this, for me, is one of the major positives that have come out from this trial. Now, if you look at the primary endpoint of doubling of serum creatinine or end-stage renal disease or CV or renal death, again, if you look at a 30% relative risk reduction with a fantastic confidence interval, and if you look at the point estimate looking wonderfully towards the positive side, it is a very robust positive data which has come out as the primary endpoint. And there is no, towards the end of the study, the graphs coming closer to each other. That is not happening. It is still widening. So you see, this is a very robust finding that we have got from the CREDENCE trial. If you look at independently the endpoints, end-stage kidney disease, again, a 32% significant reduction in end-stage renal disease compared to the placebo arm. And if you look at the composite of CV death or hospitalization for heart failure or congestive heart failure, again a 31% reduction versus placebo, which is expected. We have seen that also from the primary CANVAS trial. The 3P MACE of the composite CV death, non-fatal MI, non-fatal stroke, remember this is the secondary endpoints now we are talking about. There is a 20% significant reduction in this particular endpoint. Again, a replica of what we found from the CANVAS trial. Hospitalization for heart failure, again, no-brainer, entirely seen with all, but here the difference comes in the fact that these were patients with established nephropathy. These are the patients who had a very high risk of developing hospitalization for heart failure. If we can make a difference in this population of patients, it speaks a lot. Remember, volume overload is one of the major problems in patients with CKD with a reduced EGFR. And there you find near about 40% reduction in that, I think is a very big finding, again, which has come out from the CREDENCE trial. So if you do a summary forest plot at the results, primary endpoints, look at the effect size, don't look at the p-values, they're not important. Look at the effect size, look at the confidence interval, prominently on the right side. It goes on from the primary composite outcome to doubling of serum creatinine, to ESRD, to decline of EGFR to less than 15. It is absolutely superior. Yes, the superiority is not seen in dialysis initiated or kidney transplant patients. It's too late. We have already missed the bus in those subset of patients. It didn't make a difference in renal death. Again, if you look at the confidence interval, you know why it has happened. The number of patients were too less, but the effect size is on the right side. So if renal death would have been seen in a larger population of patients, we'd have seen a positive data even from CREDENCE trial on renal death. CV death, again, is on the positive side, but it's a secondary exploratory endpoint, so hypothesis generating. And then ESSD, doubling of serum creatinine or renal death, you look at the effect size completely on the right side. So whenever the dialysis or transplant part is coming in, we are seeing that the significance is lost because there is number crunching which is going down. Overall, it is, I think, an overwhelming positive trend on all the renal endpoints, either as a composite or as the individual endpoints. Most important part, the reason why canagliflozin has been flawed compared to the other drugs as far as cells of the molecule is concerned is adverse effects. There was never any doubt about its potential as an efficacious agent, but the adverse effects have pulled it down. As I said, these are the patients who are at the highest risk of adverse events. And if you compare the placebo versus those who actually had the serious adverse events, again you find the point estimate towards the side of canagliflozin. So it is actually doing better as far as the overall adverse effects is concerned compared to placebo. They bring us to the renal safety. A lot of people were actually thinking about or concerned about acute renal injury, which is an issue with metformin, which is an issue with SARB within the first month of initiation. The same concern remains with this molecule. But if you look at the data here, any renal related endpoint, hyperkalemia, favored canagliflozin and not placebo. Even if you look at the acute kidney injury, the point estimate is on the favorable side compared to the placebo. Other adverse effects of interest, as expected, genital mycotic infection was more with canagliflozin, and more so even both in the male and the female. To me, a little bit surprising was the male genital infection showing more than the female. Could be because of the number imbalance, because there were more males who were recruited in the trial compared to the female, possibility. There was no increase in urinary tract infection. There was no worsening of volume or volume depletion, and you find that there was no increase in malignancies seen. Rather, there was a healthy trend towards reversal in renal carcinoma. Again, there was number crunching, so it didn't reach significance, but that was an interesting data. If you look at the acute pancreatitis, again, there is no increase in acute pancreatitis in subset of patients, or there was a slightly increase in diabetic ketoacidosis, which happened in 11 patients with canagliflozin and 1 with placebo. So this is one endpoint which definitely reached significance, but though the numbers were much less. Fractures and amputation are the two important endpoints we were looking. After the canvas thing has happened, a lot of real life studies had come up and actually confused us, some saying yes and some saying no. We know the only way of answering that problem would have been doing another randomized controlled trial. That's exactly what canvas is doing today. Sorry, CREDENCE is doing today. And if you look at the fracture, again we find, if you look at the confidence interval here, you find there is absolutely no increased risk of fracture with canagliflozin. Again, remember, we are recruiting in the CREDENCE trial patients with established CKD who already have damaged bone architecture at a very high risk of fractures and did not develop fractures in this particular trial. If you look at the lower extremity amputation, again, we are looking at a large subset of patients with established CKD. A lot of them will have volume depletion. A lot of these patients will be asked by the nephrologist to have less amount of fluids, very highly prone to peripheral vascular disease or amputation, didn't have that. So, you know, it is prompting a lot of us to ask the question whether whatever we found from canvas was a chance finding, just like the heart failure with saxagliptin, which seems to be a chance finding. So CREDENCE overall, if you look at, is the first CKD which dedicated phase 3 renal outcome trial of any antihyperglycemic therapy. Obviously, now is the first to come into the market. It will take the cream and the limelight. It is the only product today that we have, or only antihyperglycemic that we have, which is robust in reducing systolic blood pressure, robust in reducing body weight, robust in reducing HbA1c, and alongside reducing both macro and microvascular complications. So we can safely claim that with this particular molecule. The NNT for outcomes, if you look for the primary composite, is the most impressive. Statins, ACE, ARB doesn't come anywhere near this sort of a NNT, 22. So if you treat 22 patients with type 2 diabetes and established nephropathy, you have 1 patient in whom the outcomes will be prevented or reversed or stalled. If you look at EKSD, doubling of serum creatinine or renal death, the NNT is 28. If you look at independently end-stage kidney disease, the NNT is 43. Hospitalization for heart failure, CV death is more as replica of what we have seen from the previous trials. So what are the implications of whatever we have gone through? I will just come back for my last slide. Before I go to my last slide, first is safety, followed by whatever advantages that we have. You see, and the safety from the drugs which have been exposed to trials. We are seeing a lot of molecules being exported, or imported from Korea and China, where these molecules are not up for sale, being manufactured and packaged in India and resale. We have already shown you with losartan, irbesartan, the type of cancer risk has come up and molecules are being withdrawn. I am not impressed with molecules which have not done studies or which do not have background data with an RCT or CVOT or safety which is done. So if I have to say an SGLT2 which makes a difference from renal microvascular outcomes, it's an empagliflozin, it's a dapagliflozin, it's a canagliflozin. To qualify statement a little bit more, my conclusion slide, canagliflozin, since it reduced the primary composite endpoints of the renal outcomes, also reduces the secondary renal outcomes, also showed secondary reduction in the cardiovascular outcomes, complementing the primary cardiovascular outcomes reduction in CANVAS trial. This is at present the only SGLT2 inhibitor and the only antihyperglycemic agent to have a good metabolic effect, and as well as reduction in both micro and macrovascular complication. The blemish on it of fracture and amputation seems to be put to rest, at least in this subset of patients, and the debate can now be opened up. The questions can now be asked to a lot of regulatory authorities of how they are going to behave on the black box warnings that they already had, which now looks like a chance finding from the CANVAS trial. So yes, as I started off from my first slide, the heading which I gave, am I canvassing for CREDENCE? Yes, I am canvassing for CREDENCE. If you have such data, it is worth canvassing for CREDENCE. Thank you very much. So I'll be taking a few questions which I think must have come up by this time. Yeah. So there's a first question coming from Leena from Mumbai. Will this change the amputation concern away from Cana? Well, it's all about using the right adjective and the right noun at this particular moment. So will this going to change, or should this change, or can this change? It's up to the regulatory authorities. With this sort of a data, yes, it should. We should see a change happening in the label. We should see the black box at least being taken out from this particular from molecule, and obviously from the class as a whole. But whether they'll do or not is a completely separate issue, because we have to wait for the regulatory authorities how they respond to this data. So today is the data when it has been presented. You have to give some time for people to react. Dr. Vaibhav, which set of patients are suitable for Promenade after CREDENCE? I would have used the word canagliflozin after CREDENCE. Would have been a more generic sort of a statement made by a physician instead of using a trade name. Obviously, any single patient today is suitable for an SGLT2 inhibitor. Remember, first we need to prevent from a primary perspective the drugs. So any type 2 diabetic patient, I think above 35 years of age, should be on an SGLT2 inhibitor from now onwards. For if you want to extrapolate the data of CREDENCE, then it is those with established nephropathy, like those who have an urine ACR more than 300. those who have a EGFR less than 60 are now the candidates for the use of canagliflozin. But that doesn't mean canagliflozin cannot be used in those who do not have nephropathy, do not have retinopathy. You can use it right from day one, because the CANVAS trial actually included patients of both primary and secondary prevention cohort. So you can have the impact on cardiovascular outcomes right from day one if you use this product. So from day one to a EGFR of 30, that's where SGLT2 lies. And if you want to stretch it to 30 in patients with established kidney disease, that's where canagliflozin comes in with the extra amount of vigor compared to the other SGLT2 inhibitors for the time being. There's another question from Dr. Vaiva, which is the most fascinating point about CREDENCE. It depends whether you're an optimist or a pessimist. To an optimist, the most fascinating part of the CREDENCE has been the reduction of its primary endpoint and also associated decrease in HHF, which I think should have gone up. For a negative pessimistic point of thinking, I would have looked into the amputation and fracture part, and extremely relieved to see that they're practically non-existent or in this particular trial, or even if they're existent, they are equivalent to that of the placebo group. So we need not bother about those endpoints. And there's another question from Vaibhav. Why are serious events in CREDENCE and related what are the serious events in CREDENCE and related consequence about side effect? Well, I'm not sure about the term serious, except for the one endpoint, which is DKA, 11 versus 1, as you saw. So we need to understand about the right choice of patients, and that is expected in patients with established CKD. Remember, with the use of SGLT2 inhibitors, we always tell our patients to have that extra glass of water, extra 250 ml of fluid, not to restrict carbs and fluid. Here, the minute you have a CKD, there is a tendency, especially when you go closer and closer to say around 30. So once you have CKD stage 3B and above, there's a tendency of nephrologists to cut down on the fluid. These are the patients who might be at a higher risk of developing this problem. Moreover, a lot of these patients were also on insulin. The minute you have CKD and the creatinine starts going up, a lot of the patients are taken off metformin, put on insulin. And I don't know, we need to find out those 11 patients, what happened, where they were on insulin, and whether insulin was proactively cut down while continuing with an SGLT2 inhibitors. That is what we are not supposed to do, because that induces decay risk. But that's again a very small number, but serious, and seen across the board for most of the SGLT2 inhibitors. The other side effects are the ones that we already see, genitourinary tract infections. But apart from that, there are no other serious side effects which has come up from this trial. Devanuda, thank you for asking a question. Can we say below, I think, below knee reduce and patient on Cephas side, is that right? Below knee amputation. Well, I think overall, as we saw from the amputation data, it is absolutely same as that of placebo. There is no difference between the two. Yes, whatever we saw from the previous cutoff data on the amputation were on below knee, especially the toe amputation was quite common. Here we did not see that. We just have to wait for more data to come up, looking into the breakup of those individual adverse effects for a final answer on that. But overall, no, there is no such signal from this trial. Dr. Rajdeep Roy, any baseline BMI to avoid Cana or SGLT2? No, nothing. There's nothing to avoid. For those in whom I am bothered about the weight part, I do not use metformin. I straight away start with an SGLT2 inhibitor. For me, this is the molecule, because when we start our patients with a low BMI on metformin, the concern is the same as when we start our patients with low BMI on SGLT2 inhibitor. For me, if that's a concern, I start only with a SGLT2 inhibitor. I don't even add metformin. Please be careful. We now have recent data coming out from Diabetologia, which is just published. Initially, when a patient is detected with diabetes and presents to you, metformin actually increases hepatic glucose output in the initial stage, might even worsening your blood glucose values. In those scenarios where weight is an issue and patient is newly detected, there are no osmotic symptoms, patient is not cachectic, not losing weight dramatically, start off straight with an SGLT2 inhibitor, even without metformin. It's absolutely okay to do so. There's another question from Dr. Devon. Can you see Cana versus other SGLT2? No, I cannot. because the other SGLT2 are also having their renal data. I think they'll all be the same. From the cardiovascular perspective, they're already the same. From renal, they will also be the same. As of now, this statement is also hypothesis generating, because now CANA has it. I am not sure whether what the data with the others are going to come. I can extrapolate that it might be the same as the trend was from all the outcomes trial. But as of now, if I have to use a molecule which makes a difference on the renal outcomes, it is CANA. I cannot say it is EMPA or it is DAPA. But they are also having their trials which is going to come up, and then this question will make sense whether we can compare or not. Subramaniam, Dr. Subramaniam from Chennai, good morning. Does CREDENCE will be seen as a positive study overall? There's no doubt. We had two positive studies now from CANA. One is the CANVAS program and the second is the CREDENCE. And CANVAS program was positive from the cardiovascular perspective. CREDENCE is positive from the renal perspective. Join them together is the ideal scenario. CANVAS raised questions about amputation and fracture, put to rest by CREDENCE now. So yes, it is a positive data. It was also a positive data. I do not agree with the question whether it will be seen as a positive data now. I agree with your question that it is seen as a positive data overall if you take CREDENCE in with the perspective of CANVAS or in the backdrop of CANVAS. Yes, it's an overall positive data. Okay, a few more questions. One from Madurai, Dr. Ananda Senthil. Doctor, how long would the type 2 diabetic patient with CKD can on canagliflozin, and give some advice for examples of EGFR rate? Okay, obviously as of now you're going up to 30 because with canagliflozin, but the level change has to come. You need to know the level change as of now for most of the SGLT2 inhibitors, it's 45. But with this CREDENCE data, it should now come down to 30, which I think it can be safely done. I think that's what the regulatory authorities will be looking at. If the GLP-1 has got an EGFR of 30 without any renal benefits, I do not see why the EGFR should not be brought down to 30 with this. And I think example of EGFR rate is the rate of decline of EGFR on an annual basis. That's something which is done in most of the studies. For us, it's just patients with an established nephropathy. We need to check their EGFR every 3 to 6 months to see how the decline is happening. You can use your mobile app to do that. We have the MDRD or the CSI, CKI, MDRD, or even the Cochrane-Gault formula there on your mobile app. You can do it and see how it's progressing or not. Okay, Dr. Rahul Bhattacharya from Kolkata. There was a protocol amendment CREDENCE in 2016 taking lessons from CANVAS program, which helped them curb the amputation risk in CREDENCE. That proves amputation is not an issue if your patient selection is right. I think protocol amendment has been done by all trials. Protocol amendment was done by the EMPARAGE outcome trial. Protocol amendment was done by the DECLARE-TIMI. So protocol amendments were all done. Whatever protocol amendment you say, when you include patients with established CKD and nephropathy, which are the higher risk group for amputation and volume depletion and related outcomes, you still can't explain why you have a lower rate or rather equivalent amputations compared to placebo in CREDENCE compared to CANVAS where there was higher. You just can't had it been the reverse, we would have said yes, it tells the story. With CANVAS, predominantly those with EGFR more than 60 being included at a lower risk of those complications. Here patients at a higher risk of those complications. Remember, they also, near about 40-50% of the patients also had cardiovascular disease at high risk also of peripheral arterial disease. But why didn't it happen in CANVAS? So I personally don't feel that protocol amendment has been the reason why this amputation thing has happened. Dr. Vaibhav again, decay is very high. What could be possible reason? No, decay is not very high. Out of thousands of patients, when you just have 11 decay here, so numerically it is not very high. This is the type of decay you have seen across in most of the trials, 4, 5, 7, 11. That's all we have seen in most of the trials. So it's not very high. Possible reasons I've already discussed in my previous thing. Maybe volume depletion, maybe some of the patients were asked to restrict fluid, maybe insulin dose was abnormally reduced, unless individual cases of those 11 patients are brought in focus we cannot say what exactly was the result. Dr. Subramaniam, Chennai, what is so impressive about CREDENCE in your view? I think we have already discussed that. It's the first time in history of anti-hyperglycemic agents we have a drug which made a difference in nephropathy outcomes, along with the associated secondary difference on the cardiovascular endpoints too. And this is wonderful news, especially after the irbesartan and losartan data. This is the first time any molecule has shown such benefits. Dr. Raghu, Bangalore, do we expect cardiorenal paradigm shift for SGLT2? I think it should have happened already. Now that the renal part has been endorsed, I think every single patient should be on an SGLT2 until unless there is a contraindication from day one, until unless the EGFR permits them to do. I would not use metformin or even a DPP4 inhibitor above an SGLT2. For me, it will be SGLT2 plus minus metformin, or it will be SGLT2 plus minus metformin DPP4. I think SGLT2 should now be the first line drug along with GLP-1, which is difficult, is injectable, expensive to use early on in the process, but SGLT2 should be the first line drug. It has already been declared to be the first line drug by Melanie Davis and Kamlesh Khunti in those with established cardiovascular disease. I think with this data, this should become the first line drug for every single diabetic patient, irrespective of, unless you have contraindications. Are there any more questions? The last one is by Dr. Rajdeep Rai. Do you reduce dose of thiazide or clothianidone? No, you don't. There is no need of reduction of any thiazide diuretics. The only diuretic which requires a dose reduction is a loop diuretic when it is used along with an SGLT2 inhibitors. আর আছে? If there are no more questions, thank you very much for your patient hearing.